Good morning, everyone. Just going to give folks a couple of minutes to log in and we'll begin shortly.
And I'd love to hear, I only recognize a couple of names. I'd love to hear in the chat if folks are affiliated with the CPO and maybe what your role is. Give me a little context on how much you've thought about this stuff, perhaps.
All right, it's 3 minutes after. I'm sure folks will continue to come on in. Well, this morning, good morning, or whatever time it is where you are. We are honored to hear a presentation from Megan Lipsett, who is a doctoral student in the Department of Psychology here at the University of Oregon. I should say I'm Elliot Berkman. I'm a co-investigator on the Center on Parenting and Opioids. I direct the pilot and training core. And I also happen to be Megan's doctoral advisor. Megan came to us from the University of Colorado Boulder, where she has her undergraduate degree and a master's degree in integrative health studies. Megan has quite a range of experience in this space. She has been faculty member at the California Institute of Integral Studies, looking at kind of lifestyle practices and mindfulness training. Megan is a certified mindfulness-based stress reduction leader. And her scholarly work exists in this really interesting space between health behaviors and social phenomena like stigma. So we'll hear more about that today. Megan's been doing a lot of work thinking about the ways that social forces such as stigma or other internalized things like shame and guilt relate to health behaviors and, as you'll hear, can of course undermine the effectiveness of potential treatment for things like diabetes or other health behaviors. So I could say more, but I want to give Megan the full time. So I'll just say I'm excited to hear this. We are going to have a poll at the end of the webinar. So if you would like CME or CEU credit, please stay to the end and there'll be a poll where you can indicate your desire for that credit. And I'll also mention that this webinar will be recorded and posted on the CPO website. So without further ado, please join me in welcoming Megan to present addressing research related to stigma to improve quality of care for pregnant and parenting people affected by SUD.
Thank you. Appreciate it, Elliot. Yeah, good to be with all of you. And it sounds like the chat was disabled. So sorry I asked you to reply and then you couldn't, but you can do like Camille did and put in the Q&A if you want to just let me know anything about yourself. Otherwise, I'll assume some of us have a spectrum of ways of interacting with this group. And so hopefully we'll get a chance to support people regardless of kind of how much they've thought about this. I really want to work today to, as Elliot said, review the impacts of stigma on the healthcare provision of pregnant and parenting people with stigma, with substance use disorder. because stigma acts as a barrier to health-seeking behavior, to engagement in structures of care, and to treatment adherence. So stigma reduction strategies are needed in many sectors, of course, but I'm going to focus specifically on how we as researchers can examine the existence of stigma with our own work as part of this larger effort to alleviate the adverse effects both of stigma itself and the impacts it has on accessing healthcare services. Because this endeavor is inherently a process of reflexivity, I want to invite each of us to bring compassionate curiosity to the ways in which these deeply embedded socialized stigmas may be influencing our own work, and to check in with the natural distress that can sometimes arise when we uncover our own assumptions, taking care that this doesn't have to be a conversation that itself creates shame. I really believe that, you showed up today because you care. And I know there are also barriers to deconstructing these stigmatized socialized practices, not the least of which are often time and resources in our work. So I really thank you for taking the time to uh, give your attention to this today. I hope that some of these barriers can be removed with this information that I'll share today, and that we can all empower one another to collectively utilize the leverage and the influence that we have as researchers to engage in social change while conducting rigorous research. As a person who myself was raised by a parent with mental illness and substance use disorder, I certainly don't want to, through this talk, undermine any of the suffering related to these conditions, but rather to look critically about the ways that stigma ultimately acts as a barrier to care. I've done my best to balance this limited time we have together with an orientation to what is known about the issues, a couple of activities to directly explore these issues today, and then resources moving forward as well. So as Elliot noted, my research and community-facing work is really focused at the intersection of health and psychology, especially looking at the life course health and well-being impacts of psychosocial stressors among a variety of populations with high adversity. So I'm not an expert on substance use disorder or perinatal health. And on that note, I'll acknowledge the co-authors of the paper where this webinar is largely being drawn from. So Katie Weinstein, Simone Mendez, Estelle Berger, Elliot, Mishka Turplin, and Camille Cioffi, some of whom are on this call, or as you know, associated with the CPO, and this paper was done under the CPO as well. So you'll notice as well that I've included QR codes on several of the slides today. So you can access the resources throughout, and I'll ask Ashley to send these to you as well so you can find them later on. Okay, so basic facts about substance use disorder among pregnant and parenting people, for those that may not be involved primarily with this. Good to see your chats coming in, and great to get to know a little about you. Okay, so it's of course pretty difficult to estimate this accurately, but it's thought that about 1 in 8 children live with a parent with substance use disorder. We know that the efficacy of evidence-based therapeutic interventions has been established with benefits for individuals, for families, for societies. We also know there are harm reduction approaches that exist, like behavioral strategies that parents can implement to help ensure child safety, supportive medications, testing strips to avoid unintentional fentanyl exposure. Yet, only 1 in 5 people report receiving the treatment they need. Of course, these low treatment rates are driven by multiple structural factors, but fear of shame and stigmatization in seeking care remains one of the key determinants of treatment engagement. Indeed, substance use disorder, as many of you know, is actually the most globally stigmatized health condition according to the World Health Organization. And the National Institute on Drug Abuse has identified stigma reduction as a major priority. Stigma can be understood as an attribute, behavior, or reputation that is socially discrediting. And it occurs both formally, as with officially sanctioned terms like criminal, and informally, as when someone refers to an entire identity as a particular attribute, which we know this prejudice can lead to discrimination. And there's a pretty large body of research showing that stigma towards these individuals is persistent, it's pervasive, and is often rooted in the belief that misuse of substances is a personal choice, reflecting a lack of willpower or a moral failing. Um, some of the strongest influencers about our perceptions and beliefs of both mental and substance use disorders tend to be our degree of knowledge about the disorders, as well as the degree of contact or experience that we've had with people with mental and substance use disorders. Of course, media has a huge reach, and portrayal of people with mental and substance use disorders is a huge influencer, as well as generally media coverage about tragic events, and most notably those that include gun violence and suicide. The portrayals of people with mental illness are often violent in the media. Treatment is often depicted as unhelpful, and this is thought to really stoke fear and intensify the perceived dangers of people with substance use disorder. Which we said that we're talking about really complex attitudes, beliefs, behaviors that are present at many levels of our research process, right? In the development and the conducting of research, all the way to dissemination phases, where our research products interact with different levels of society and unfortunately may unintentionally reinforce some of these prejudicial attitudes and discriminatory practices against this group. And this matters because stigma arising during the delivery of research can itself create negative experiences and outcomes for study participants. It can impact adherence to the study. It can also impact our awareness about relevant study events. Beyond this, it's a fundamental cause of health inequities across the life course. And we know that it's racialized as well. So there's, the degree of social stigma that exists varies dependent on the substance that's used. And oftentimes this has more to do with racialized narratives surrounding that substance than specifically to the pharmaceutical impacts of the substances themselves. We know that stigma also impacts the quality of care. So stereotype perceptions endorsed by healthcare professionals are associated with diminished empathy, as well as disregarding patient autonomy, worse patient outcomes, quality of care, and type of treatment delivered. And then, stigma also impacts the children of the parents who use substances. So for instance, medical conditions can be erroneously assumed to be connected to substance exposure, and this so-called diagnostic overshadowing impacts both parents and children. Stigma can similarly influence our theoretical approaches and the interpretation of our research findings, where we may incorrectly disregard important participant comorbidities or inaccurately assume that some of them are a feature of substance use. So this three-level model is often used to talk about the levels of social stigma, and I've given some examples here, but broadly, this is structural levels, right? Laws, regulations, policies, as well as social or public stigma, our attitudes, beliefs, and behaviors. And then self-stigma, when this negative stereotype becomes internalized by the individual. And all of these influences compound to create the barriers to harm reduction, treatment utilization, and quality of care that we're talking about. And indeed, the misuse of substances has even been posited as a self-regulatory strategy to manage a lot of difficult life experiences, which includes stigma-related social anxiety and experiences of racial discrimination. So this is, multi-level, which means we need multidisciplinary and multi-level ecological approaches to understand and address the stigma. And that, of course, includes involvement of researchers in engaging in reflexivity within our research practices. Okay, so how we articulate and contextualize our research findings can have consequences for intervention uptake, for public perception, even for policy, and the way that practitioners perceive, communicate, and treat pregnant and parenting people with substance use disorder. Stoll and colleagues, who are individuals with lived experience of substance use, stated that those of us who have conducted human research have noticed that beliefs about addiction are incorporated into every aspect of it. The framing of the questions, the screening criteria, experimental manipulations that are used, the outcomes measures that are used in clinical trials or in assessments. And most of those beliefs are based on data and are defensible, says Stoll, but often they do not allow for the degree of heterogeneity that we know from experience is characteristic of addiction. Okay, so I want to ask you to do a little reflecting, and I can't see you all, but if you want to, you could consider closing your eyes or just sort of bringing your attention to your mind's eye. And we're going to give ourselves a little activity to just check in with some of the socialized narratives that we might have been exposed to ourselves. So I want you to just imagine this person you see, Jennifer, we'll call her. You may take out a pen and paper or just reflect for yourself to just notice what kinds of things come up, whether you feel like you would endorse them publicly or not, what some of the associations that arise for you are when you hear that Jennifer consumes cocaine and other illicit drugs, and that she has recently become pregnant. So Jennifer's parents are worried for her and for the baby because they believe she is an addict. And her doctor recently told her that the baby is underweight. And so now she's contemplating what her relationship to cocaine is going to be. So just taking a few minutes to reflect compassionately but authentically on some of the stigmas that may arise in your own mind when you think about Jennifer. And while we're just going to be keeping these privately to ourselves, I would just ask you to consider, what are some of your private beliefs or assumptions or some of the images that arise for you about pregnant and parenting people like Jennifer who use substances that you would not feel comfortable saying out loud? No need to respond, just taking a moment to reflect on that. Okay. So whether you experience these or, you're exposed to these, I know, many of you have been in this work for a while. So just to name some of the common beliefs about this group that often arise, which are, one, that they're dangerous, that they're unpredictable, and then especially for parents in this group, that they're incapable of providing a supportive caregiving environment. And third, that these so-called attributional stigmas, that is the belief that people are solely to blame for their behavioral health problems. These beliefs are especially high in healthcare professionals as well as Americans, who are more likely to believe in the dangerousness of people with mental illness than are citizens of other developed nations. We also see this prognostic pessimism, a questioning about the ability to recover, to become a normal member of society, and then endorsements of social distance, right? So Maybe I feel that I can accept Jennifer, but I wouldn't want Jennifer to marry into my family, or I may not want to share a home with Jennifer, or I may, maybe would I consider Jennifer to babysit my children, for instance? And then, of course, endorsing beliefs about maternal unfitness overall. So while, some of these features can be true of a particular individual, of course, today we're speaking about the harm that can be caused when these stereotypes are applied to entire groups of individuals. So when these perceptions get applied to an entire group, oftentimes it's due in part because of a lack of contact with those of lived experiences. So for instance, we as researchers who study this population may not have had the opportunity to observe pregnant and parenting people who use substances acting as competent parents or recovering from substance use disorder. So these are the 6 strategies for reducing stigma that we've outlined in this paper, which of course you can reference later. I'm going to try and go through all 6 of these to differing degrees for us. Hopefully, some of these you can consider integrating into your work. So the first is to address our stereotypes, our prejudice, our misconceptions about this group, because these might influence public and self-stigma, right? So here we're hopefully developing a clear understanding about stigma and the effects that it has. We're becoming aware of and responsive to self-stigma that we might observe in patients or in participants. And we are also hopefully using continuing education, self-evaluation tools, professional trainings. So I've put links here for the Journal of Substance Use and Addiction Treatment Lived Experience, which we'll engage with in a moment, as well as the Perinatal Harm Reduction Coalition harm reduction toolkits. So I think both of these are great resources, as we start to build more and more awareness about this group. So I'm going to put a link here. If you aren't using the QR codes, I'm going to put a link in the chat to the Journal of Substance Use and Addiction Treatment Lived Experiences page. So if you don't mind, take a minute or two to head that way and browse through some of these lived experiences articles. I'm going to be quiet here for about 3 minutes or so to just give you a chance to go browse and hopefully bookmark this page on your screen and just, notice what you see and if any of your perceptions get kind of activated as you're reading some of those experiences. So check that out. The link is in the chat, and we'll have a couple minutes to go and peruse. Oh, thank you. I sent the link to hosts and panelists, so that is not helpful to you all at all. Here you go. So I hope some of you had a moment to go just browse through some of those and flag. Maybe you want to read those from time to time. I know for me it was helpful in just having many examples of people's lived experiences. In case you were not able to access that for any reason, I pulled out just one little excerpt here. There's an article written by 3 addiction treatment professionals who share their lived experience of overcoming substance use disorder, highlighting how education and careers have formed the cornerstones of their recoveries. They say we also link our experiences to the emerging recovery capital literature, which speaks to the importance of employment in the substance use disorder recovery process, while highlighting how systemic racism and the crimes against humanity committed in the name of the war on drugs remain barriers to many pursuing education and new careers. So I think just hopefully inspires us to see the kind of richness that someone with lived experience can offer to a collaborative research team and to help us notice stigmas that we might have. There are some pretty good trainings that are out there if you want to go deeper into this work as well. So a couple that are more specific to this population are the mental health first aid trainings and Zero Block Society trainings. And we might be able to increase our understanding of those individuals, especially when we think about those who experience unwanted habitual behaviors related to substance use. I think we can develop empathy when we recognize the difficulty of changing our own deeply embedded habitual and unconscious beliefs and behaviors, both, those that show up in our day-to-day lives and in the ways that we examine our habitual beliefs about parents with substance use disorders. Each of these is arguably motivated by our unquestioned social norms or strong emotions like fear. So, from this place of recognizing our common humanity and noticing the way in which our degree of social leverage and access to resources that we have as researchers, I know some of us are also mental health professionals here too, of course, both positions with leverage and resource access, to be able to use that to recognize that we have a really strong influence on the way in which the natural human impulse towards reducing suffering and making sense of the world manifests, whether through use of substances or any number of coping mechanisms. We know that the normative judgments that exist, whether unconscious or conscious, are reflected in our scientific endeavors and perpetuate stigma. So these anti-stigma interventions are really designed to help us present more factual information about these conditions, correct misinformation, contradict negative attitudes and beliefs. And looking at the research on these interventions and trainings themselves, it seems that those that help us to expose our normative judgments and then encourage opportunities to have really meaningful contact with communities that are the focus of our research tend to be the most enduring. These so-called contact based interventions are really designed to overcome this interpersonal divide that we often have with our participants. And I think that somebody from Zero Block Society came to speak to the CPO, so I hope you're familiar with this. And just to name that, I think there maybe even is a recorded lecture from the ED of Zero Block Society, so you can go check that out as well on the CPO website. And then just wanted to highlight this training that's coming up on May 14th. That's specific to stigma and substance use prevention. It's a 2-part. This is the first one. And so another opportunity to continue exploring this. So maybe one of the most accessible steps that we can take to improve inclusivity and reduce stigma is through the language we choose in our science communications, which influence public perceptions. Some common suggestions are to avoid slang terms like abuser and clean urine, and also idioms like, falling off the wagon. It's not always intuitive, and so community-informed resources for destigmatized terms are out there. Most often use a dictionary and then NIDA's Words Matter resource. So we'll explore those in a moment, and of course, they're constantly evolving. And then in addition to using destigmatized and community-informed terms, we can strive to use factual medical terms. And I even saw, Cynthia, you used one of my examples in your description, which I appreciate. The term, we used to maybe say opioid substitution therapy, and as Cynthia's using, this has been replaced with medication-assisted treatment. So this can kind of help us to avoid conflating a physiological dependence with a compulsive behavior, and then perhaps more accurately speaks to medication as one controlled component of treatment. At the same time, it's important to not assert, for instance, that prescription treatment is a whole person approach, and that multiple approaches are needed. And then, of course, person-first language, which we can use to emphasize the person over their condition, and reflect respect and dignity for all people. So as I think many of us are now used to, people with opioid use disorder as opposed to opioid users, for instance. We can also look at recovery-oriented language to kind of refocus the lens from pathology and suffering to one about resilience and healing, and one that kind of acknowledges the long-term nature of the modalities and strategies needed to sustain recovery. One other thing that we can do, and I'll mention again later, is to consider adding narrative accounts of competent parenting or recovery among pregnant and parenting people with substance use disorder to our research dissemination products. So lots of work has been done to look at the use of terms in forming our perceptions. So this is an often cited, actually set of 2 studies that were looking at the difference between the word abuser and substance use disorder. And so, the idea being that abuser implies volitional acts of willful misconduct, and it's associated with things like child abuse, whereas substance use disorder can be a clearer term. Interestingly, substance use is kind of uniquely talked about this way, right? So people with eating related conditions are almost always referred to as having an eating disorder, not as food abusers. So studies like these 2 by Kelly and colleagues are designed to show how these word choices matter. They essentially found that the mere use of the term substance abuser versus having a substance use disorder led to beliefs that individuals with substance use disorder engage in willful misconduct, that they pose a greater threat to society, and are more deserving of punishment, among other things. And this was done both with a group of urban citizens and a group of mental health practitioners. Okay, so Ashley, let's see, can we do breakout rooms in here or no?
Uh, we should be able to. Give me one second.
So no pressure to do a breakout room if you're like walking your dog and, calling in or whatever. I understand. The structure of our lives tends to be that way. But I thought we could go and take a look at a couple of resources that were mentioned. The first, a dictionary, and to just review some of the terms and check out for ourselves what the terms are that might surprise us. Maybe there are things that we disagree with, and maybe we could consider how might we incorporate this into our research, and what are barriers to implementing these. The second resource that I want to ask us to explore together is from the Prevention Solutions Group, the Words Matter resource. And this one is really designed to be able to kind of take to our manuscripts or other research products and use as kind of a checklist to look at, with a critical lens as to whether we might be engaging in things that unintentionally are creating stigmatizing aspects to our research. And so I'm going to give, again, these QR codes are here, but I'm going to give you in the chat box the direct links again. So this one, I will, oh, I see. Okay. It looks like we don't have breakout room, so we'll be creative. So I'll just invite everyone then in here, and it's fine, we're a small group anyway, to check out this link. So if you go here, you'll see this kind of toolkit, including, for instance, these 5 questions to ask ourselves. And then I'll also give you the link to the dictionary. And to go for a minute and check out these terms, there's a list of terms and their definitions, and then right under the term, it in some cases says stigma alert. And so maybe paying special attention to those that say stigma alert, and would love to just hear from some of y'all about your thoughts about these, if any of them were surprising, things you might disagree with, etc. And then as well, taking a look at this Words Matter resource and letting me know if you think you might be able to utilize this in your work or barriers you might see. Oh, I see. All right. So I'm just getting to know the features of this webinar here and seeing that unmuting is actually not the easiest thing for y'all. So, and looking at the time, I'll just say, if you have any thoughts or comments, you might post them in the chat. And otherwise, you could bring it up perhaps at the end in about 10 minutes when we have Q&A and discussion. So at very least, please consider bookmarking those resources, especially this one here on language use. Okay, so next strategy would be to engage in interdisciplinary and transdisciplinary collaborations, which can help us to understand and address stigma that we know is this kind of complex and multi-level social phenomenon. So collaboration can really help us to weave in multiple streams of evidence generate more practical and robust knowledge. Of course, the writing of the paper on which this webinar is based was very collaborative, and I can say was just hugely valuable in seeing multiple perspectives and really, taking time to be discerning on what we included in the paper and, just illuminating things to one another we wouldn't have otherwise noticed. And of course, ideally, this includes working with researchers with lived experience. They are often especially good at connecting to community stakeholders and can provide valuable insight into things that we can do to reduce stigma. And then collaboration can, of course, go beyond that with other researchers and academics. This can be challenging for many reasons, but also incredibly valuable and one of, I think, the most important approaches to stigma reduction. These participatory approaches involve really actively engaging community members and stakeholders like family members, advocates, healthcare practitioners, really into every stage of the research process. And, we can sometimes start with even just adding a community advisory board to look through our materials, to give feedback. But ideally, and in true community-based participatory research, the stakeholders are really included as active partners in understanding the problem, in describing potential approaches or interventions, in describing the theory of change, in identifying which methods to use or which measures to use, and then as well as even collecting the data and making sense of the findings. Beyond representing these ethical standards of inclusivity, there have been meta-analyses and systematic reviews that have demonstrated that the CBPR approaches can improve utilization and treatment outcomes for evidence-based substance use treatments. Ideally, we're engaging someone with clinical and/or facilitation skills within marginalized populations. Taking on CBPR, of course, requires commitment to being in true partnership and working with community leaders long term. I think that you may have seen this if you were able to go to the ED's talk from Zero Block Society, but this is a really great resource to begin with if you haven't been exposed to it yet, the Research 101 Manifesto, to help get oriented to learning from highly researched communities like the Downtown East Side in Vancouver, about how to conduct these practices in ways that really treat the communities with respect and dignity. They outline these pitfalls that are often arising in those collaborations and growth opportunities, as well as these kind of expectation setting guidelines to help to avoid ruptures that might occur. Of course, this is just one valuable resource. They're growing. And the Patient-Centered Outcomes Research Institute, or PCORI, is another great resource. They provide grant funding. There's also an online repository of engagement-related tools and resources, including these stakeholder engagement plans. And so I've linked these examples of these stakeholder engagement plans. They also offer a template, but you can go through, I think there's 5 or 6 of them that just give an example of how individuals, propose to work with communities in these kind of dynamic and iterative ways that are required. And all of the, the value surrounding these plans are outlined by PCORI as with the intention of building trusting relationships with community partners, allowing their input to define the evidence collected, critically reflecting on and dismantling power structures, exploring potential adaptations relevant to the community being considered, engaging in critical evaluation of how scientific frameworks and approaches may contribute to barriers by perpetuating stigma. Cool. And Karen, I see your chat, which I'll probably look at in a few minutes when we get to the discussion. Excited to read it. Okay, next strategy is providing contextualizing information about the social and environmental factors that influence use. A lot of scientific frameworks for understanding substance use have commonly been decontextualized and exclusively focus on kind of internal and behavioral mechanisms like self-regulatory processes or habit extinction. While individual level factors are certainly related to the trajectories of this disorder, a failure to kind of nest those within the broader context might actually influence self-stigma and stigmatization within the treatment system. So we can sort of be intentional about incorporating social, environmental, genetic factors, right? Naming things like the influence of disparities in healthcare delivery, of racism, social exclusion, which have all been demonstrated to be determinants of substance use as well as parenting outcomes. These structural factors, along with fear of related stigma, ultimately can drive treatment engagement. So I hope we see it as supporting a shared goal. We can do this through really acknowledging predictors that or factors that are robust predictors of outcomes beyond substance exposure alone, and looking into using models like biopsychosocial models, socio-ecological models can potentially help minimize some of the moralization that is occurring. And you might check out, it's referenced in this paper, but it's sort of a synopsis of another paper from Mishka Turplin, one of the co-authors, who's talking about some of the current weaknesses of our statistical models for representing the heterogeneity that exists for individuals, and also weakness of those statistical models in being able to represent the kind of compounding impacts of intersectionality of those with multiple stigmatized identities. Again, another opportunity here to consider adding individual narratives to our research products that can kind of humanize the individuals who are the focus of our research. And then last bit here, to advocate for stigma reducing policies in research articles and other scholarly products. So to consider naming policy impacts, how our samples within our papers are being impacted by policy. You might also consider directly writing policy briefs if you haven't already. And this is a paper that I've referenced before and find to be helpful. If you haven't written a policy brief, it can be very intimidating. And then once you do, I think it actually feels pretty accessible. At least it did for me. And this paper, How to Write a Health Policy Brief, was one of my guiding stars in that. And then I'm sure if Camille is on, I think she told me she had to leave early, but she can certainly speak about the research to policy collaboration, which is, I think, another really great resource, because of course the agenda and the language in policy is equally as complex and jargon heavy as that of the academic space. And so there are individuals at the research to policy collaboration that have really trained in kind of bridging that gap and helping us to understand, looking at, when there are policy windows where our policy briefs are more likely to be seen, and other really valuable information that we likely aren't thinking of as academic researchers. So there have been funding opportunities specifically for this. I think this one was quite a while ago, so this is no longer available, to be clear, but I'm just putting it here to say the NIH has funded projects for specifically for decreasing stigma in substance use. And so it's something, that has been funded before. And so with more general funding opportunities, you may consider referencing that and just appreciate that, it has been a priority in previous times and hopefully remains one. And here's references, even more references. And I'll stop there and give time and space for questions. I always like to invite dissent. I think it's so important to have, dissenting opinions in these really complex conversations. If you have more insight or resources you want to share, or we can just discuss here. So thank you so much.
And Megan, thank you. And I'll just jump in because I know Elliot had to step away. As did Camille, but also for those of you who are from wanting continuing education units, you will have, I think, just seen the little poll pop up there on your screen. And so if you complete that, that will initiate the process for getting the CEU credits. So while folks are doing that, I just want to say thank you, Megan. That was just a wealth of amazing resources. And I know this is not the largest group today, but I know there are others who had a strong interest but just couldn't make it today. And I'm so grateful that if you're all right with you, we'll be able to post your slides, because the different resources and links that you provided are, you can get little doses of it in these kinds of webinars, but having them to refer back to, as you noted, I think is just a real benefit of what you just shared with us today. So I want to thank you for that. We do have, I'm not sure if Karen would like to speak to her point that she raised in the chat. And actually, I'm not sure I don't know that I think our participants are not able to speak. I think that is the way the webinar is set up, but I don't know, Megan, if you want to respond to Karen's comment or if we should also just see if there are other points of clarification or question or dissent, as you noted from folks in the room.
Yeah, maybe I'll just read it out loud so I can orient and everyone else can too. So, issues of drug addicted babies is not only unwise, as babies are born with many issues. The current and most effective solutions for addressing many birth trauma or health issues involve contact and support of the mother and family in the period following birth. The inclusion of baby moms in recovery from birth is discouraged by negative labeling like this, as you mean negative labeling like drug addicted babies. And I think maybe you saw that in the dictionary, I'm gonna guess, or just in your own practice. It discourages best practices of closeness, warmth, and supportive feeding that are hospital-based approaches that help babies and families most. Yes, thank you so much for bringing that in. I think that's so huge, right? That is one of the major issues. And Karen, I'm feeling so curious about what you're up to in the world and how you're working with this. But I think I completely agree with you that this parent-baby bond and community support and warmth and care tend to be really thwarted with stigmatized practices, and unfortunately really inadvertently or sometimes intentionally can cause that really important bonding period and support to the mother baby and parent baby to be lost. So thanks for bringing that up. Good. Yes, people are saying they're sharing their resources. I'm so glad. I was talking with my colleagues about this and saying, like, I don't want people to feel like I'm just, like, you don't want to come to a webinar and it's like just telling you about the other thing you should do. But I do think, of course, this is like a process to engage with long term. And so I hope that, you got these and you can sort of bring them to your teams and think about how can we apply these for ourselves. And I mean, even the writing of this paper was such a, self-reflective process, right? When you're trying to do something as bold and shameless as giving strategies and suggestions, to your own field, then it feels so important to be doing the thing that you are suggesting. And so it was a really rich process to, take this work and think about, well, how are we really integrating this in what we're doing, and what does that look like? So that includes, bringing in other co-authors when we realized there was sort of a gap in experience and things like that. So I hope you will spread these resources far and wide. And also, this is constant learning process. And so I would love to receive resources that folks have found beneficial as well.
Well, thank you, Megan. I think we're just about at the top of the hour, so I think we'll go ahead and wrap up for today. But I also just want to put a plug in. I do think, because we will post these, this would be, kind of the way you structured the webinar, I think would be a great small team activity for those of you who are, as some of you may have noted in the chat, just sharing with your teams. I think we have this webinar format so that we have more accessibility, so people from all over can join, but it would be nice to do in person, face-to-face, in small teams. So thank you, Megan, for sharing your expertise, your insights, and all the resources. Thank you, participants, for joining. And if you have additional questions or comments, please do feel free to reach out to Megan or us at the Center on Parenting and Opioids. And thank you for all the great work you are doing out there.
Yeah. Yeah, I second that. Thank you, everybody.
Thank you.